Welcome to the deep dive. You might think of a sinus issue as, well, just a bad head cold.
Right.
You grab some over-the-counter decongestants, maybe a box of tissues, and you just sort of wait it out. It's a nuisance. But today, our mission is to explore what happens when that nuisance becomes a severe chronic reality.
It's completely different ballgame.
Exactly. We are pulling from an excerpted chapter of a specialized surgical textbook focused on endoscopic sinus surgery, specifically this procedure called the ethmoidectomy. And let me tell you, stepping into this source text, it changes the picture completely.
Oh, absolutely.
We are talking about a surgeon navigating this bony, three-dimensional labyrinth that is located dangerously close to your brain, your eyes, and major arteries.
It really requires a profound shift in perspective. I mean, when you read through this kind of highly specialized literature, you realize very quickly that this is not about treating the sniffles.
Yeah, not even close.
The core philosophy established right up front in this chapter is that an ethmoidectomy is never your first option. It is a highly calculated, precise intervention. And it's really designed for patients with chronic rhinosinusitis or severe nasal polyposis.
Okay, let's unpack this, because jumping from a stuffy nose to, millimeter precise surgical intervention inside the skull, that is a massive leap.
It is.
The source text makes it very clear that nobody just walks into a clinic and gets this surgery on day one.
Right, the clinical threshold is incredibly high. Surgery is only considered after aggressive medical therapies have completely and utterly failed.
Like what kind of therapies?
Well, the text details patients who have been through extensive rounds of culture-directed antibiotics to fight persistent infections. They've used daily topical therapies, they've taken, heavy courses of systemic steroids to force down the inflammation.
Wow, so they throw everything at it.
Exactly. But despite all that, they are still suffering from significant anatomic obstruction. Their sinus cavity is basically choked with diseased tissue or polyps.
Just completely blocked.
Yeah, to the point where those medicinal sprays cannot even physically reach the areas they need to treat.
So the medicine fails because it's hitting a physical roadblock, basically. And the surgical team has to go in to clear the path. But you can't navigate a labyrinth without a map.
No, you definitely cannot.
So before a surgeon ever picks up a scalpel or an endoscope, the text outlines the absolute necessity of creating a highly individualized blueprint of the patient's skull. They require a dedicated maxillofacial CT scan, specifically with a 1 millimeter slice thickness.
And that 1 millimeter slice thickness is not just a recommendation, it is an absolute prerequisite.
Just 1 millimeter.
Yeah, because in the confined space of the ethmoid sinuses, a single millimeter is literally the difference between clearing a disease cell and, well, causing a catastrophic complication like blindness or a brain fluid leak.
Hold on, I gotta push back on this bit. Human heads are all laid out roughly the same way. We all have eyes, we all have brains, we all have sinus cavities in generally the same spots. Why can't a surgical team just use a highly detailed, generic 3D map of a human skull? It's like planning a bank heist, right? You just need the standard floor plan. Why does every single patient need their own specific millimeter by millimeter scan before they can even be scheduled?
Because human anatomy at the microscopic level is wildly, terrifyingly unpredictable. It is not like the standardized plumbing in a house.
Really? It varies that much?
Oh, massively. The text dives deep into a concept to explain this, called the Keros classification. This is a system that measures the depth of the olfactory fossa.
Okay, what is that?
That is essentially the area where the skull base, the bony floor of your cranial cavity where your brain rests, dips down above the sinus cavity.
And I imagine it dips down at different depths for different people, which is where the danger comes in.
Exactly. The Keros classification divides this unpredictable geography into 3 types. Type 1 is a relatively shallow dip, about 1 to 3 millimeters deep.
Okay.
Type 2 goes down 4 to 7 millimeters. But a type 3 classification is a deep, dramatic plunge of 8 to 16 millimeters.
Wow, 16 millimeters.
Yeah, so if a patient has a type 3 anatomy, their brain is essentially hanging significantly lower into the roof of that sinus cavity. The surgical workspace is incredibly compressed.
Which means less room for error.
A much, much higher risk of the surgeon accidentally piercing the skull base and causing a cerebrospinal fluid leak.
Which is a literal hole leaking brain fluid into the nose. That is deeply unsettling.
It really is.
The surgeon might think they're just scraping away a polyp at the top of the sinus, but if it's a type 3, the brain is sitting right behind that thin layer of bone. And speaking of hidden dangers, the text also mentions the search on these CT scans for something called Anodi cells.
Right, Anodi cells are a perfect example of why a generic anatomical map would be disastrous. This is an anatomical variation where an ethmoid air cell, one of the many little honeycomb-like bone compartments in your sinuses, does something unusual. It pneumatizes backwards.
Meaning it hollows out and fills with air as it grows, pushing itself further back into the skull than it normally should.
Correct. It grows directly over the sphenoid sinus. And by pushing that far back, it brings the surgical area terrifyingly close to the optic nerve.
Which controls your vision.
Right, and the cavernous sinus, which houses the carotid artery. If a surgeon is clearing what they think is a normal ethmoid cell, but it's actually an Anodi cell, they might find their instruments right up against the major blood supply to the brain.
Oh, wow. The text also points out something fascinating about how the internal dimensions can actively deceive the surgeon's eyes. It highlights the relative height of the ethmoid cavity compared to the maxillary sinus, the large sinus under your cheeks.
Yeah, what's fascinating here is how these spatial relationships create optical illusions.
An optical illusion inside the skull.
Literally, yes.
Yeah.
If a patient has a really large cavernous maxillary sinus, it distorts the surgeon's perspective once they are inside of the camera and makes the ethmoid cavity above it look deceptively short.
Huh.
It essentially tricks the brain into thinking the skull base is much closer than it actually is. It's a psychological trap.
So the surgeon memorizes this map. They check the Keros type to know how low the brain is hanging. They hunt for hidden Anodi cells near the optic nerve. They account for the optical illusions.
They have to account for all of it.
But knowing the map isn't enough. The surgical team then has to physically manipulate the patient's body to cooperate, which leads to some incredibly counterintuitive anesthesia tactics.
Oh, the anesthesia protocol for an ethmoidectomy goes far beyond just putting the patient to sleep.
Yeah.
You have to remember, you are looking through a tiny millimeter-wide endoscope camera.
Right.
The slightest drop of blood completely smears the lens, turning the monitor bright red.
Here's where it gets really interesting. To prevent that bleeding, the textbook reveals the use of something called total 4 anesthesia, or TIVA. They bypass the traditional inhalation gases you usually associate with surgery.
Right, the gas can actually promote bleeding.
Exactly. And the anesthesiologist uses intravenous drugs to deliberately maintain the patient's heart rate at exactly 60 beats per minute and the mean arterial pressure at 60.
The entire cardiovascular system is being intentionally suppressed. The lower blood pressure means the tiny capillaries in the nasal lining won't bleed as vigorously when cut.
It's like trying to do delicate microscopic watch repair underwater, but first you deliberately drain the muddy swamp so you can actually see the gears.
That's a great way to put it.
And the local preparation is just as aggressive. They pack the inside of the nose for at least 10 minutes with these little surgical sponges called pledgets.
Yeah, and those pledgets are soaked in a very specific, potent chemical cocktail. It's a 50-50 mix of oxymetazoline and lidocaine.
Oxymetazoline being a powerful vasoconstrictor, it rapidly shrinks the blood vessels down to almost nothing.
Right, while the lidocaine acts as a topical numbing agent.
Plus, the text outlines targeted injections of epinephrine and lidocaine directly into the region of the sphenopalatine artery and the axilla of the middle turbinate. And just to translate the medical speak, the axilla is basically the armpit or the anchoring corner where that nasal structure attaches to the sidewall. But wait, stepping back for a second, isn't artificially driving a patient's heart rate and blood pressure down to 60 extreme? You are purposely suppressing someone's life support system just to get a clearer camera view? That sounds inherently dangerous.
Well, the alternative is actually far more dangerous. As the text establishes, you are working in a tiny, bony box, mere millimeters from the eyes, the optic nerve, and the brain itself.
Right, the real estate is terrifying.
Exactly, right. If the patient's blood pressure is normal, the moment the surgeon makes a cut, profuse bleeding fills that box. The endoscopic camera is instantly blinded. A blind surgeon waving sharp metal instruments near the optic nerve is a recipe for tragedy.
So lowering the heart rate is the lesser of two evils by far.
The text treats it as a non-negotiable safety parameter. In fact, it establishes a hard rule. Profuse bleeding is an absolute contraindication for this surgery.
Meaning they just stop.
If the anesthesiologist cannot get the pressure down, or if the local injections fail to shrink the vessels and they cannot establish a clear visual field, they abort the surgery entirely. They wake the patient up. You do not proceed blind in the ethmoid sinuses.
Wow. Okay, so assuming the field is perfectly clear, the heart rate is strictly controlled, the actual physical journey into the ethmoid maze begins. And the text outlines that the surgeon has to follow a strict, unyielding sequence of 4 anatomic landmarks.
It is a very deliberate path.
Right. So step 1.
The first step is identifying and removing the ethmoid bulla. A bulla is essentially a hollow, blister-like bubble of bone that sits prominently in the nasal cavity. Surgeons use a specific instrument called a double-ended J curette.
A curette being a tool with a tiny loop or scoop at the end.
Yes, and they work in a strictly anterior or forward pulling motion. They gently pull that bone bubble apart. They have to do this with incredible care because removing the bulla safely reveals the most critical boundary of the entire surgery, the lamina papyracia.
Lamina papyracia literally translates to paper-thin layer, and this is the medial wall of your eye socket.
Exactly.
It is the single, fragile, eggshell-thin sheet of bone, keeping the surgical instruments from sliding directly into the patient's eyeball.
The tactile feedback the surgeon feels through their instruments here is everything. Once they safely identify that paper-thin eye wall, they know their lateral boundary. Then they move to step 2.
Which is?
They have to traverse a bony divider called the basal lamella. To get through this wall, they switch tools, often using a sickle knife.
But the textbook gives a massive warning right here. It explicitly tells the surgeon to preserve the horizontal portion of this basal lamella divider. Why is that specific piece of bone so sacred?
Because that horizontal piece of bone acts as the structural anchor for the middle turbinate.
Okay, the middle turbinate.
Right, which is a large, fleshy, shelf-like structure in the nose that helps humidify the air you breathe. If a surgeon aggressively hacks away the horizontal part of the basal lamella, the middle turbinate loses its structural support.
Oh, I see.
It becomes a loose, floppy piece of tissue that can collapse outward and physically block the drainage pathway for the frontal sinus above it, causing an entirely new, massive infection.
So they punch through the divider carefully, preserving the load-bearing support. That brings them to step 3, identifying the superior turbinate. We just mentioned the middle one, but the superior turbinate is this tiny, fleshy shelf located incredibly high up and far back in the nasal cavity.
Finding the superior turbinate is essential because it is the navigational beacon for the deepest part of surgery. It points the way to the sphenoid sinus. Without finding it, a surgeon is just guessing in the dark.
Which leads right to step 4, the final landmark. They have to find what the surgeons ominously call the corner.
The corner, yes.
This isn't just a turn in the maze. It is the ultimate safety checkpoint. It is the exact specific junction where the skull base from above, the anterior face of the sphenoid from behind, and the orbit of the eye from the side all meet in a single point.
Finding the corner means the surgeon knows exactly where they are in 3-dimensional space. The danger of getting lost is over. From there, they can safely finish the dissection.
And how they conduct that final dissection is where the text introduces the concept of mucosal sparing techniques. This part is crucial. The text mentions using very specific tools for this, particularly a 45-degree through-cutting forceps.
Right. Instead of using standard forceps that grab and tear tissue, which risks stripping the delicate lining right off the bone, a through-cutting forceps acts like a microscopic hole punch.
It punches cleanly through.
Exactly. It cleanly bites through the bony partitions, making a very distinct mucosa bone mucosa cut, leaving the surrounding tissue perfectly intact.
Okay, let's pause on this. The surgeon is taking all this extra time to hole punch the bone cleanly just to save the mucosal lining. But if this lining is already massively diseased, if it's covered in chronic inflammatory polyps and causing the patient total misery, why bother saving it? Why not just use a tool to scrape the whole sinus cave, completely bare down to the bone to guarantee you got all the disease out?
This raises an important question to the whole philosophy of the procedure. The overarching goal, according to the text, is a functional surgery. Your sinuses are not just empty pockets of air to lighten your skull.
Right.
The mucosal lining you're talking about is covered in microscopic air-like structures called cilia.
And these cilia act like a microscopic conveyor belt. They're constantly sweeping back and forth to clear out mucus, trap dust, and regulate your local immune system.
If a surgeon goes in and aggressively scrapes that cavity raw to the bone, they destroy that entire biological conveyor belt. Bone doesn't just grow back new cilia, it heals over with thick, non-functioning scar tissue,
So you'd fix the blockage, but you'd be left with a sterile, scarred-over cavern that can never clear mucus on its own ever again.
which leaves the patient functionally worse off than before they had surgery. The mucus would just pool and stagnate. Mucosal sparing technique is designed to remove just enough bone to open the physical bottlenecks while preserving the microscopic biological machinery so the sinus can eventually sweep itself clean again.
It is an incredible balance to strike. But even with these strict landmarks and this absolute dedication to preserving the anatomy, the medical textbook reveals that surgeons are actually fiercely debating what to do with one specific piece of the nasal architecture.
Ah, yes. The great controversy over the middle turbinate.
Exactly. Traditionally, the middle turbinate, that fleshy radiator shelf in the middle of the nose, is treated as sacred ground. It's preserved because it humidifies air, and more importantly, it's a massive, unmissable physical landmark in the middle of the surgical field.
Right.
But the text highlights an evidence-based medicine debate. If that middle turbinate is diseased, or if it becomes destabilized during surgery, a growing number of surgeons advocate for just cutting it out completely. A middle turbinate resection.
And the clinical data supporting this resection is highly compelling. The text cites a systematic review that compared patients who had their middle turbinate cut out versus those who had it carefully preserved.
And what did they find?
The findings shocked traditionalists. Removing it did not negatively impact the patient's quality of life. It did not cause a spike in postoperative frontal sinusitis. In fact, patients who had it removed often reported better postoperative olfaction scores.
Their sense of smell actually improved because opening up that space allowed more airflow to reach the scent receptors higher up.
Exactly.
So what does this all mean? I look at the middle turbinate debate like dealing with a load-bearing wall during a house renovation. Half the contractors are looking at the blueprint saying, do not touch that wall, you'll ruin the structural integrity of the house.
Right.
And the newer contractors are looking at the data saying, actually, if we tear it down, it opens up the floor plan, the air flows better, and the house functions better for the people living in it.
That's a great analogy.
But here's my question. If the hard data proves that taking it out improves smell and doesn't hurt quality of life, why is it even a debate anymore? Why not just remove it every single time to give the surgeon more room to work?
If we connect this to the bigger picture, you have to look beyond the clinical data and understand the psychological environment these surgeons are operating in. Otolaryngology is a surgical field saturated with medical legal risks.
You mean malpractice lawsuits?
Yes. The threat of a lawsuit for a surgical complication is a constant looming reality. And the middle turbinate isn't just a piece of tissue. It is the major safety landmark that physically separates the nasal cavity from the cribriform plate, which is where the brain sits.
Ah, it's not just a biological structure, it's a psychological anchor for the surgeon. As long as they can see it, they know they aren't in the brain.
Precisely. Removing it unnecessarily violates a surgeon's deeply ingrained, almost instinctual training to preserve natural anatomy and maintain their navigational waypoints.
It's a comfort thing too.
Yet, even if a study says it's generally safe to remove, if a surgeon chooses to cut it out, and later there's a rare complication, the loss of that primary navigational landmark will be intensely scrutinized. So the debate rages on, Trust the data that shows functional improvement, or trust the surgical instinct for anatomical preservation and legal safety?
That tension between the cold, hard numbers of a clinical study and the very human pressure of actually holding the scalpel is fascinating. But, whether that turbinate stays or goes, the surgical procedure eventually ends.
Right, the surgery's over.
The blood pressure is brought back up, the patient wakes up, and they go home. But as the textbook strictly warns, the patient's journey is far, far from over once they leave the operating room.
Oh, the post-operative reality demands extreme, rigorous compliance of the patient. Because the skull base and the paper-thin eye orbit have just been operated on, the architecture is incredibly fragile.
They have to be so careful.
The patient absolutely cannot blow their nose. The resulting pressure spike inside the sinuses could blow air directly into the eye socket or the brain cavity.
Oh, that's horrifying.
If they feel the urge to sneeze, they are strictly instructed to do it with their mouth wide open to safely vent that pressure outward.
On top of that, they have to perform daily high-volume saline irrigations. We aren't talking about a gentle nasal mist. They are flushing 240 milliliters of fluid, about a cup, through those raw, healing sinus cavities every single day.
Yeah, to manually wash away the blood clots and crusting.
And if they had severe polyps, the text notes they are often placed on a rigorous 3-week tapering dose of steroids, starting at a heavy 32 milligrams and slowly stepping down to brutally suppress any recurring inflammation.
And this brings us to perhaps the most sobering truth outlined in the entire textbook chapter. After all of this incredible effort, the 1 millimeter CT scans, the intense anesthesia protocols, the millimeter by millimeter hole punching navigation past the optic nerve and the brain.
Yeah.
There's no known cure for chronic rhinosinusitis with polyposis, or for cystic fibrosis related sinus disease.
Wait, really? After taking all that risk and breaking into the skull, there is no permanent cure?
No cure. The text states explicitly that this highly complex, dangerous surgery is merely an adjunct to ongoing medical therapy. It is not a permanent fix.
That is wild.
It is simply a way to clear the physical obstruction so that those daily topical steroid sprays and saline rinses can finally reach the diseased tissue.
Sure.
It resets the clock, and it improves quality of life dramatically, but it does not stop the underlying inflammatory disease from existing.
That is wild to wrap your head around. You go through all of that. You map out the cranial bank vault. You medically drain the swamp. You dodge the optic nerve by a millimeter. You painstakingly preserve the microscopic cilia conveyor belt.
Yeah.
And at the end of the day, it is just to give a bottle of nasal spray a clear path to do its job.
It highlights the ultimate limits of applying mechanical solutions to deeply rooted biological problems. The surgery is an absolute masterclass in human anatomy and technical skill, but fundamentally, it is a management tool. It is not a definitive endpoint.
Which leaves you with a pretty profound, lingering thought to chew on as we wrap up. If this incredibly intricate, millimeter-precise surgery navigating brain bases and paper-thin eye walls is ultimately just a temporary lead-pulling exercise to clear space rather than a permanent cure, how much of our modern medical intervention is really just treating the architectural symptoms of our biology? What would a true microscopic biological cure for chronic inflammation actually look like? And if we ever finally invent it, will it eventually make this beautiful, terrifying surgical labyrinth completely obsolete?